Welcome, everybody. Thank you, everybody, for joining us today. I'll just wait a few more seconds to allow people to log on, and then we'll go ahead and get started. All right. Okay, everybody. Good morning, good afternoon, good evening to everybody from around the world. My name is Kieran Agarwal-Harding. I have the pleasure of chairing this third and final session of our Ortho-Pediatrics and Oncology series. Thanks so much to all of you who've participated in our last two sessions. We had two pediatric orthopedic sessions, one on limb deformity, one on chronic osteomyelitis. That was really fantastic, and those are all recorded and available online. Today, we're moving on to the oncology side of things. We're going to be talking about primary bone tumors. We have some excellent cases lined up and some really superb faculty. So let's just jump right in. I'll hand it off to Emily to run us through the introductory slides.
I think Abdullah actually will take it.
Oh, please, Abdullah. Sorry about that.
Well, hello, everyone. My name is Abdullah Njai. I'm a second-year orthopedic surgery resident at the University of Missouri. So I'll be co-moderating with Dr. Agarwal-Harding. As for our course agenda, so like Kieran stated, this is the third installment of our orthopedic pediatrics and oncology session. So for this session, we'll be focusing primarily on primary bone tumors. Next slide, Emily. I know we've all been using Zoom for a while now. But just to say that we do have the option to use the show captions feature. This will also allow us, given that we have such a global scope for this program, to have individuals actually use closed captions in the language of their choice. So all you'll have to do is use the caret feature where it says show captions, and that will allow you to choose a language of your choice for translated subtitles. Since we have a large number of participants as well, we want you all to be engaged. Feel free to use the raise your hand feature, and we'll call on you as we go through. Also, you can use the chat to put in questions or comments you'd like to state as well. As for the course objectives for this program. So the first, to improve participant knowledge of limb deformity, chronic osteomyelitis, and today focusing primarily on bone tumor principles. In addition, I think one of the key things is fostering international discussion. So thankfully, we have individuals from across the globe sharing their expertise and perspectives on these cases. And we'll be focusing today primarily on oncology and the management of complications. And then for our third and final, basically objective, really focusing on motivating and supporting the younger generation of orthopedic surgeons practicing in resource-limited settings. And you all had a chance to meet Dr. Kieran Agarwal-Harding, who's our course chair. And then I'll be serving as our moderator. I just want to give a special shout out to our HGOC and SONA global organizing team. This wouldn't be possible without everyone behind the scenes. So just want to give you all a shout out. And then as for our case presenters, so really want to give you all a special shout out for taking the time to submit such incredible cases. I'm looking forward to the discussion we'll have today. So our first one, Dr. Fabiola Meza from Mexico, Dr. Nick Were from Kenya, Dr. William Gishe from Tanzania, Dr. Walid Meki from Sudan, Dr. Zubair Khalid from Pakistan. And then as for our case discussants, so we have Dr. Megan Anderson from Beth Israel Deaconess, Boston, Massachusetts, Dr. Cecilia Benzorina, who will be representing the University of Missouri in Columbia, Missouri, Dr. Amanda McCoy, who will be representing UPMC, Children's Hospital in Pittsburgh, from Pittsburgh, Pennsylvania, in the United States. Dr. Mark Gebhardt, Beth Israel Deaconess Medical Center, Boston, Massachusetts. Dr. Carrie Heinzelman from Beth Israel Deaconess Center as well from Boston, Massachusetts. Dr. Saad Ilyas from Pakistan. Dr. Nicholas Okumu from Kenya. Dr. Deepak Ramkumar representing Harvard Medical School in Birmingham, Massachusetts. Dr. Kevin Raskin representing Mass General Hospital in Boston, Massachusetts as well. And then Dr. Mir Thacker, who representing Nemours Children's Health in Wilmington, Delaware. As for our course agenda, so we've started with our introduction. We have several case presentations as well. With our case presentations, we're going to try to keep them to about 10 minutes. I think we really want to emphasize the importance of the discussion with each case. But we'll actually be starting with Dr. Nicholas Okumu, who wants to give a brief presentation on the challenges of setting up orthopedic oncology services in resource-limited settings. So first, we'll hand it off to him. And Dr. Okumu, if you don't mind pulling up your slides, we'll hand it off to you.
I hope my slides are visible.
Yep,
Yep,
they're
great.
great. Thanks.
And thank you guys for the opportunity to share. I'm not purporting to be presenting any new information, just highlighting the challenges that we face when we try to have this kind of specialized service in our parts of the world. So this actually falls into the context of a global surgical crisis. And if we were to look at oncology specifically, 80 to 90% of cancer cases involve a surgeon. And especially when you look at solid tumors, surgery is almost always essential for diagnosis, staging, curative treatment, or palliation. But overall, taking care of an oncology patient is a multidisciplinary approach. And if we want to actually get better results, we need to improve the surgical pace. And an overview of orthopedic oncology, just as a definition, I am assuming everybody here knows what that is, and the fact that the treatment involves not just surgery, but also other aspects such as chemotherapy and radiotherapy. So what's the importance of orthopedic oncology when we look at healthcare? We want to essentially, hopefully get early diagnosis, which improves our survival rates. The economic impact, if we do timely treatment, reduces costs. And also, lastly, we think we should be thinking of quality of life. And in this aspect for orthopedic oncology, the focus is around limb salvage and allowing our patients to keep function and mobility. And it's also a very good area for research with so many things that we could study. For example, right now we are doing work on in AI to look at diagnostics, screening, and even development of prosthetics. So you can see that this is a very ripe research field. And so what's the issue in low and middle income countries? Basically, it boils down to one thing: our survival rates and limb salvage rates are too low. I'm quoting statistics here from a recent study we did, where our survival rate in our local setting at KNH was only 15%, and we only do limb salvage 5% of the time. And this is in contrast to the other part of the world where survival rates are above 70%, and 95% of the time you're able to do limb salvage surgeries. So sarcoma treatment around the world is basically modeled around treatment of patients in focus centers using a multidisciplinary approach. And this model has proved successful. So we need to bring that model to our African setting, our low and middle income countries, to achieve the same results, 70% survival, 95% limb salvage rate that we have in the global north. So what are the challenges that we're facing in Kenya and other LMICs? Firstly, it's just infrastructure. We're having a challenge with the lack of diagnostic facilities, the fact that patients have to travel long distances to get treatment, and the fact that we have limits in terms of our surgical theaters because we don't have the specialized equipment that is available elsewhere in the world. Of course, there's a human resource challenge. For example, if I speak of Kenya, we only have 2 orthopedic oncologists. And in other parts of Africa and the world, that specialty doesn't actually exist. And then on many occasions when we train as professionals in these areas, we often find opportunities that are better in other parts of the world. So we are living a system where the available healthcare workers are overburdened and face heavy workloads. There's also a cost aspect, which is, I think, the biggest element that we need to solve. If you look at doing a limb salvage surgery even just in the Kenyan setting, the minimum it would cost is about $10,000. So you can see that, and majority of our patients are spending this money out of pocket with limited funding sources. So cost and financial challenges is actually probably the biggest barrier to setting up this kind of service. So there are opportunities for us to improve, and what we're asking for is international collaboration, forums like this, but even more to build capacity and share resources. We can use technology such as telemedicine and using AI and other tools. And hopefully at the end of the day, what we're trying to do is even bring manufacturing of things like prosthetics and implants to our part of the world. And some key solutions would be helping us to achieve more specialized training. I don't think there's a single training center that gives orthopedic oncology training on the continent of Africa outside of South Africa and Egypt. So only 2 countries on our continent can train orthopedic oncologists. That is not an optimal situation at all. And then we need to reform the way we do health financing, and this includes orthopedic oncology. We still need to increase awareness among the public and even help changing policies so that referrals can be more direct. So what we need is innovative solutions. And in this article here, I actually suggested that because sarcomas are actually not very large in number, setting up something like an endowment or a trust to take care of the financial costs for these patients would be actually something that can be game changing. And so we are in the process here in Kenya of setting up a Kenya Sarcoma Foundation, which will be a trust that will handle financing and care of these patients. And we hope that we can get support for that. And we've mentioned that we are working on improving awareness, both among the general public and even in the primary care setting. And very soon we'll be releasing a training manual for primary healthcare workers and another one for awareness in schools and universities where our target age group, the highest number of sarcoma patients will present. So in conclusion, my call to action is help us by collaborating, and hopefully we can make this better. Our service has been running here in Nairobi for the last 4 years, and we have had a bit of success, and I'm hoping that this is a model that can be adopted across the world in low and middle income countries. Thank you for your time.
Thank
Say that there's hope. When I was listening to his early slides, it reminded me that when I started orthopedic oncology, it was fairly similar. Most patients had an amputation. Most patients died. There were very few orthopedic oncologists. And over the past 40 years, that's been able to change. We didn't have quite the financial restraints, but there's also things that improve, like as exemplified by this conference, where a lot of things can be done electronically over the web for consultations, and both for pathology and for education and consultation. There are now machine learning tools that can help primary care people analyze an X-ray to help them decide whether a case should be referred or not. So I think there's a lot of tools that we can use to help improve the situation. Probably the biggest concern is how do you pay for the special studies, but we used to do limb salvage without MRI, and it can be done. India and other countries have developed prostheses that are much less expensive than the ones we use in the States and work pretty well. So, I mean, I think it seems like there's a lot of ways that we can make things better on the African continent.
Yes, thank you very much. Dr. Fabiola, would you like to continue to your presentation?
Yes, thank you.
As you pull up your slides, I also just want to give another shout out to Dr. Nicholas Okumu to all the amazing work he's doing in Kenya. The manual, the training manual that he mentioned, and also the endowment are really innovative ways of addressing these challenges. So
Hi, thanks for the invitation. Welcome everybody. Thank you for joining. I'm Dr. Fabiola Roscon, currently in the 3rd year of residency from Mexico, based in La Paz, Baja California Sur. Today I'm going to present the case of a 12-year-old boy who presented a proximal tibia destructive lesion. My objectives on this presentation is to take the importance of correlating clinical biopsy and other studies, the need for a multidisciplinary team, and the prognosis in this type of persons. The case begins when we received a 12-year-old boy who presented a pain and swelling under his left knee with apparently no relevant background. He mentioned that 1 month before he was attended by a doctor because he fell off his bicycle and had pain in the lower leg extremity, where he got prescribed some NSAIDs. 3 weeks later, he was referred to this institute, but now presenting limitation to normal activity, and he had no relief with NSAIDs. We proceed to take an X-ray and corresponding labs. The labs show us a hemoglobin of 11.9, erythrocyte sedimentation rate of 50, alkaline phosphatase 330, DHL 231, C-reactive protein 4.06, and the rest of the laboratories were normal. So we took an X-ray above inferior extremities. We can see on the anterior posterior X-ray on the left proximal tibia an isolated lesion in the proximal tibia metadiaphysis with a destruction of the middle cortex with characteristic of an osteolytic lesion with a reactive periosteum. We can also appreciate the sign of Cotman triangle. And on the right side, we have a lateral X-ray where we can see the left extremity with the same characteristics of an osteolytic lesion. So on the clinical exam, we found the vital signs, they were normal. He have claudicant gait, he have swelling below the knee, a solid mass in the proximal leg that measures 10 times 7 centimeters, involving soft tissues, pain during palpation, and pain in knee flexion and extension. He have motor strength, sensory function, and reflexes were normal. So we made a CT scan of the chest. We can see here some pictures and a video of the CT scan. We didn't found anything like nodules or other tumors. It was normal, completely normal. So we proceed to do an MRI. On the left side, we have a simple coronal plane where we can see a large osteolytic destruction on the middle proximal tibia with annexation to soft tissue. It goes to all the compartment. The lesion shows a primitive corrective periosteum, edema in medulla, bone about 15 centimeters long, and a volume of about 70 millimeters. So we decided to do the first biopsy. We decided to do an incisional biopsy. The first biopsy confirmed a low-grade fibroblastic proliferation with bone trabeculum without atypia. So due to the fact that clinical and radiological results were making sense to us, we decided to do a second biopsy, and
show it to a oncopathologist medical. So we can see right here the second biopsy. We see blue cells, blue small cells with scanty cytoplasma and hyperchromatic nuclei. We do some immunohistochemic markers, CD99 plus NKX2.2, and they were positive. So we can say we were watching an immunosarcoma. So we have to refer our patient to a third level hospital because we don't have Oncopediatrics over there. They took another X-ray. We can see that the lesion was bigger and it sent to soft tissues. He started chemotherapy as long as 2 months. And at 3 months, we decided to do a bone scan. In the bone scan, we have hypercaptured images on the ankle. So we decided to do an amputation. On the macroscopic anatomic, we found a lesion in the epiphysis and metaphysis with extensive fibrosis corresponding to almost 70% of its totality and about 50% of necrosis. There was no residual neoplasia in the epiphysis, but we have residual neoplasia in metaphysis. In the lower third of the tibia astragalus and calcaneus, we didn't have no residual neoplasia. This is a photo of the clinical amputation, how you can see. And here we have an X-ray after the amputation. So our discussion was, well, this was a tough case for us. And this can tell us a real case of what we can confront in different levels here in Mexico. The first thing we can see was our biopsy. You could be asking why we didn't do a different biopsy in this case. And I can say we don't have a training of doing a corneal biopsy. So that's why we determined to do an incisional biopsy. The other thing to discuss was our pathologists. In these cases, it's really important to have an expertise pathologist in sarcomas so we can have an opportune diagnostic and treatment. Also, deciding doing an incisional biopsy implies that like an orthopedic surgeon will make the final surgery for this patient. Our issue was that we have to do a biopsy so we can refer our patient to another hospital so he can receive his chemotherapy and final treatment. And for us, this was valuable time and for the patient. This could even make us change our prognosis. Unfortunately, we can say we give him a right diagnostic and he received his treatment. Even though we have to amputate his lower leg, we can say it was a satisfactory case. And another thing to discuss is to do another type of studies. Maybe you could be using like PET scan for associating metastasis, but unfortunately, we don't have this type of specialized studies in our city. Finally, I can say we are satisfied on our case, but we also recognize we have to do a better job on this type of cases, like having a real protocol for this type of patients. And well, that's it. I think there are different opinions from the experts, like doing the biopsy or doing a multidisciplinary team, or maybe someone can decide to do an amputation or over resection. I think these patients are valuable the time, so we have to make that great effort to do an opportune diagnostic and treatment. Thank you.
Thank you, Fabiola. Excellent presentation and difficult case, highlighting many of the challenges. I'll open it to the faculty. Nicholas, since you just gave a fantastic lecture to all of us about the challenges and limited resource settings, I'll leave it up to you to make the first comment.
So firstly, just congratulations on the good job done, despite the challenges you're facing. You've mentioned correctly that actually normally we would advise the biopsy to be done by the surgeon who will do the final treatment. And in your case, we can see the challenge that you have is that your referral system requires the biopsy results before you can refer. And I think this is one of the things I was mentioning, that policies sometimes are not optimal for management of our patients, and probably we need to consider changing that, as we are also intending to do in our setting here in Kenya. The other thing I would say about the treatment, Ewing's typically responds very well to chemotherapy, and actually it's one of the tumors we get excited about because even when it's fairly large, we are sometimes able to downstage it with chemotherapy and actually do a limb sparing surgery. And it not always do you need you know, like a complicated type of implant, because like, for example, in this patient, the fibula was unaffected, and that could actually be a very good interposition if you were able to downstage the tumor with chemotherapy to fill the defect in the bone. But overall, I must say this was well handled in the circumstances, and the outcome is still good for the patient. Thanks.
Thank you.
Thank you for your comments. Dr. Belzarina?
Thank you so much. Yeah, again, congratulate Dr. Fabiola on that case. It was a tough case. Just to put things into context, I want to say I'm in the United States now, but originally I was in Uruguay and also in Brazil. So I am familiar with working in an environment where resources were limited. I just have a question for Dr. Fabiola. Did you guys do the amputation because of limited resources in terms of implants, or what was the decision behind the amputation?
Yes, we don't have the implants in that state. We have to refer it to directly to Mexico City or to another state, so it can proceed to do the prosthesis or the surgery section if you want to do it.
Right.
We didn't have in that time that it was. It's very it costs a lot.
Yeah. So, Abdul, do you think I can share my screen? Because I would like to share something that I think is very useful. Because, like I said, working in Uruguay and Brazil, we had limited resources. Implants were not widely available, and we managed from our friends from Argentina. They perfected the allograft technique, and then in Uruguay and Brazil, we imported a technique from Japan that is called recycle autograft. And I don't know if I can share here.
Yep.
And I can show you, okay, let me show you a quick picture here. So this is kind of basically the technique. So you do the dissection and then you sink the bone in nitrogen. And then I have here a case that is just like yours. It's a tibia. So you can see here, the tibia was like fully dissected and then sink in it's just a bucket with nitrogen, which is very cheap. So you put the bone in nitrogen for 20 minutes, it kills the tumor and you're able to put it back. And in this case, as you can see here, even the epiphysis was safe. The physis is kind of close there, but the epiphysis was safe. And this is pretty cheap. There is, yes, an initial investment because, for example, my friends who imported that to Uruguay, they had to initially travel to learn how to do it. But once you learn the technique, it's very, very cheap.
Okay, interesting case.
Yes, yeah.
Nice, thank you.
Thanks for sharing. Very interesting. Any other comments from our faculty on that last case?
The one thing about, I was thinking the reason he did the amputation was because of the distal tibia uptake on the bone scan. And we've sort of, in the United States, moved to mostly PET, and I'm not sure it's any better, but these nuclear scans are so sensitive that altered weight bearing can cause areas on the affected side to look hot. And even though they weren't tumor, and I think you said you didn't find tumor around the ankle. So that bone scan may have been sort of a false positive, and it's good to be aware of that. And then the only other comment is there's certainly nothing wrong with doing an open biopsy. We used to do them all the time. Now we almost never do, and I'm not sure it's a good thing. But Dr. Campanacci used to say the intern can do the amputation or the resection, the attending. The chief surgeon should do the biopsy, because I suspect what happens on your first biopsy is you biopsied the Codman triangle, and the second time you got the tumor. So, when you do an open biopsy, it's not just a simple case that you send a medical student down to do. It should be somebody that really understands the pathology, so that you get the tissue you need. I don't know if you have access to frozen section, but we used to always do frozen section, just to, not that we were going to make decisions based on a frozen section, but just to confirm that we had tumor.
Thank you for those comments. Dr. Raskins?
Yeah, there's a reason why I have all these implants in my office, because they get infected and they fail, and amputations are sometimes wonderful, because these aren't so wonderful all the time either. So I think your management of this case was absolutely within the standard of care, and this is a very difficult age group to reconstruct with implants, and I see absolutely nothing wrong with how this case was managed. Well done.
Yeah, if anything, I
Thank
think
you.
we don't do enough amputations.
Thank you for
That's what
everybody.
Dr.
I agree,
Elias?
and oh, no, please.
Yeah, hello everyone. Sorry, I joined a bit late today. Actually, I wanted to share because I just posted a link to a very nice paper which my center published in the chat group for tibia massive bone locks. Actually, a medial fibular transport using an Elizarov frame. So that's something to look at. It's not that difficult, and especially in patients who are not skeletally mature yet, it's a very nice way of filling the tibial massive bone defects in cases like these. So you should. It's a good paper which I think we should look at.
Thanks, Dr. Elias. Dr. Heinzelman, did you want to make a comment?
Oh, I was just kind of going back to the biopsy comment, and like Dr. Gebhardt said, I mean, we have cases where maybe we haven't gotten tissue, or I really commend you guys for stopping and saying something isn't, right about that first biopsy result too, which is a huge, I think, piece of the case, honestly, and going back and getting another one, because we'll do an open biopsy, if we're worried about needle biopsy, getting enough tissue or targeting right. So I think that's a key part of this as well, is recognizing that and putting everything together with it. So I think, yeah, I totally agree with the comments. Handled very well.
Wonderful. Well, thank you all for those comments, and great case, Fabiola. Thank you very much. I think you
Thank
took
you
us.
very much for the opportunity.
Next, I think we have Nick Were. Nick, do you want to pull up your slides?
Hello, everybody. Am I audible?
Yep, you are, and we can see your slides if you just want to make them full screen.
Amazing. Great. So my name is Dr. Nick Were. I'm an orthopedic resident at the University of Nairobi, Kenya, and I'll be presenting a patient, 19-year-old boy called man.
Yeah, I think so. Continue, please.
Great. So was looking at the history of presenting at the symptoms. So it's been over 3 years with the progressively increasing mass on the right iliac region. He didn't have significant pain, but was walking with a Trendelenburg gait with a bit of a limp. He had weight loss, night sweats, fevers, and fatigue, no bowel or bladder symptoms, and was able to go to school and attend to his regular tasks. He is a known schizophrenic patient on medication and follow-up. On examination, he was stable, no of his pallor, jaundice, cyanosis, or lymphadenopathy. There was apparent limb shortening because of the tilt of the pelvis. Abdominal exam was essentially normal as far as the abdomen was concerned, but on the right iliac region, there was the mass extending down to the upper thigh, about 24 by 25 centimeters. It was firm, fixed, and non-tender. He had normal neurology, normal pulses, and a positive Trendelenburg. The rest of the systemic examination was normal. These pictures were taken with consent and just showing the mass at presentation. We did total blood count, kidney function, liver function, and INR that were normal. And just looking at the imaging, this was the pelvic CT that showed the expansile heterogeneous mass at the right iliac lesion with significant lysis of the right iliac wing. There was no encasement of the vessels. We'll just look at the report shortly. Looking at the axial cuts as well, you're able to see it's both on the medial and lateral side with a significant soft tissue component. This is the MRI that shows the same, so you're able to appreciate this mass. And also there's a preservation of the right hip joint. This is another axial cut of the MRI showing the extent of the mass and the vessels. The common iliac vessels were preserved, those just abutment of the vessels, but no significant infiltration. It's another scan. And this is the CT angio that we opted to do as we were discussing to see to have our surgical options. And it was noted that there was no involvement. As you can see, the femoral artery goes all the way down. There's no obvious involvement. Just looking at the images, the reports, this was of the angio, stating that the iliac and inguinal branches of the external iliac are patent. The distal right common iliac and vein were contacting the mass but not encased. The right external iliac and vein abutted the mass and were displaced anteriorly on the entire course but not encased. The right internal iliac artery and vein abutted the mass as well. The venous structures were also abutting but not encased, with an impression of a consistently aggressive bony tumor with a large soft tissue component and no neurovascular structures. And just looking at the CT scan, there was one that was done earlier. And after the treatment of the chemo and radiotherapy, it was noted that the mass had increased. There was a 40% increase in size, hence a decision to continue with surgical intervention. This was a PET scan that was done with an impression of there was no obvious evidence of PDG, PDF uptake in any other part of the body. And it was localized to the right iliac region. So for the histopathology, the microscopy showed small round cells with no particular differentiation, and immunohistochemistry showed positive vimentin and CD99 with a confirmatory diagnosis of an Ewing sarcoma. So looking at the history of treatment, he was diagnosed in August 2022. Thereafter was put on six cycles of chemotherapy, ending 2023. He was lost to follow-up due to one reason or another. He didn't present to the clinic, and when he did, there was a decision to give him 3 more cycles of chemo, then 31 cycles of radiotherapy. And after the radio sessions ending in April 2024, an MDT decision for a surgical excision was made. Though at the meeting, there were some reservations from some surgeons to surgically intervene, but yeah, the decision was made. Now, after the 31 sessions, we opted to have a pre-surgical embolization to help control the intraoperative bleeding, and that was done. This is just a picture of the tumor post-radiotherapy. There was no significant decrease in size. This is a picture of the embolization procedure that was done a day before the operation. And thereafter, we teamed up with the cardiothoracic surgeons who made a radial incision and controlled the internal iliac vessels. And the orthopedic team came in and extended the incision down with an extended Smith-Peterson approach and dissected soft tissues all around the tumor and did an osteotomy at the root just at the supraacetabular region. Grossly, there were clear margins, but you'll see the postoperative radiology. I think it would be interesting to discuss this. Intraoperatively, we took about 6 hours, 2 hours for the cardiothoracic team and 4 hours for the orthopedic team. Transfused 2 pints of blood, gave him crystalloids. Of note was that we dissected the femoral nerve of the tumor and also had to transect some branches, some small branches of the tumor. Hemostasis was well achieved, and looking at the intraoperative EGA, it was fairly normal. We are mainly doing it to monitor his fluid or blood requirement. So these are the intraoperative pictures. Basically just mid-dissection. We're just going around the tumor capsule. And on the right was the final excision. You can see at this area, this is where we osteotomized at the supraacetabular region, but most of the tumor we were able to get with the surrounding soft tissue. It's just around here where we had to do the osteotomy and nibble some parts of the tumor around the supraacetabular region with an aim to preserve the hip joint. So I think that's another important area of discussion. So post-operatively, we left 2 drains in, and there was appropriate stains and appropriate tenderness of the wound post-operatively. He was able to take oral sips after about 3 days and passed to after 1 week. He remained catheterized because of concerns of infecting the wound. So there was prolonged catheterization. Also, the drain drained about 300 ml in total, and it was a fairly normal exam. The total blood count done post-operatively, his hemoglobin was about 13 grams per deciliter. The dressing was clean, appropriately stained. There was appropriate tenderness. There was a bit of bowel distension, but that improved over the next few days. For the musculoskeletal, there was reduced muscle bulk and tone because we had a significant transection of the soft tissue around the tumor. The patella and Achilles tendon reflexes were present. Dorsalis pedis was also present. There was normal power and area distribution of the femoral nerve, importantly, because of that dissection. And there was normal sensation of the right lower limb. This is just a picture of the post-operative status. This is the post-operative X-ray showing the area of the excision with the drains in situ. And you can also note the preservation of the hip joint, though there was some lytic regions around the superior acetabular roof, which will be shown better on the CT scan. You can notice the significant excision of the anterior, middle and anterior aspect of the iliac wing with an intact right hip joint. With the coronal part, you could see the lytic regions around the acetabulum. And once we noted this, we knew we hadn't gotten everything out. The aim was to preserve the hip joint. So the plan was to proceed with post-operative radiotherapy so that we can get rid of the residual tumor while maintaining function of the hip joint. This is the 3D reconstruction of the same. Another part. So our major challenge was the large defect in the iliac ring, creating a need for pelvic reconstruction. Of note is that the patient is non-weight bearing. We have encouraged him to sit in bed, and he's currently undergoing physiotherapy. Another challenge we have is that he has a small superficial surgical site infection, about 1 centimeter. It's clean, undergoing regular cleaning and dressing, but this hinders our approach to have him have the post-operative radiotherapy done. So that has slowed his management. Also, the goals of reconstruction are for structural stability, to reinforce the pelvis, to allow weight bearing, which we haven't achieved yet. Functional outcome, to maintain the leg length and hip function. So just looking at the options in our setting, we could do it non-surgically. We could use the titanium mesh with bone graft. We currently don't have allograft available in our setting, so we mainly have to depend on the autologous bone grafts. And 3D printed prosthesis, which I would be keen if any members of faculty have been able to use to reconstruct the pelvis. So the preferred option in our setting is the use of the titanium mesh, of which we can combine with autologous bone graft from the contralateral iliac or the fibula. And this would be the best cost-effective option, and basically showing that the mesh would reinforce the pelvic structure and allow him to weight bear as the graft promotes the biology. So we've also thought about filling the defect with bone cement, and this is basically to considering that, with the health insurance, it may not be able to cater for the titanium mesh. So we have to put all options on the table. Of course, the advantages are immediate structural support and ability to weight bear, availability, the reduced risk of infection because of antibiotic component, and minimal need for vascularized graft. Disadvantage would be this reduced biology and risk of thermal necrosis and long-term structural integrity, and potential for cement loosening. So we also thought about combining with other methods, post-operative radiotherapy once our wounds are healed. And this would be advantageous because bone graft exposed to the radiotherapy may compromise the healing.
Nick, I just want to encourage you to wrap up so we have enough time for the discussion.
Okay, I'm actually done. This just to emphasize the need for multidisciplinary approach with all the significant teams, and we're really looking forward to feedback from this forum. to be able to continue management for the patient. Thank you.
Great, thank you so much. Any comments from our faculty on this one? Is Deepak there? Dr. Ramkumar? No, well, that's okay. Any of the other faculty? Dr. Raskin, Dr. Heitzelman, I see you on the line.
Sorry, Karen, I just had a loss of my internet connection here. You know what? This is a fantastic case. I think you know, given the overlying pathology and kind of the large tumor size, I think you know, the resection went off beautifully. Margins were negative, and I think you know, a flail or lack of reconstruction, in this case, you actually have the preserved hip joint, is probably a very acceptable option for this patient. I think functionally, how did he ultimately end up doing?
Well, he's able
So
to
currently,
sit,
oh, sorry.
he's able to sit in a wheelchair, which is, we haven't encouraged him to weight bear as of now. And as Nick mentioned, there's a wound that we're still managing before we can get him to start his post-op radiotherapy and chemotherapy.
Yeah, I think fantastic. I think overall, you know, in a situation like this, I think the lack of reconstruction is probably better. As you guys have already pointed out, there has already been a wound issue. I think less foreign objects that you have, you know, obviously the less likelihood of an infection, of a, you know, a devastating infection. And so, you know, I think a lack of reconstruction in general would be my preferred approach.
Dr. Raskin?
I agree with Deepak's comments. I think less is more, especially in the pelvis, because the downstream complications are quite significant. Infection, loosening. I wanted to ask, how big of a problem is a leg length discrepancy in this patient or in your patients in general?
As of now, he has no leg length discrepancy.
But I mean, generally
we-
speaking, is it difficult to provide shoe lifts? Is it socially unacceptable? I'm just naive to what a leg length discrepancy means in your patient population.
Okay. In Kenya, actually, one benefit of having a disability is that you're exempted from taxes. So you find patients who even try to to convince us to give them the disability status. So I think from that perspective, they might push for that. But yes, it creates a level of stigma in the community, and that's a problem that many patients would not want to have. So they would prefer, if at all, if we could preserve as much of functional performance as much as possible. But it's possible to get things like shoe raisers and other things to adapt the patient to the setting they're in.
I understand. The reason I ask is because in a case like this, with an osteotomy above the acetabulum, the sacrospinous and the sacrotuberous ligaments are intact. So without a reconstruction, which that would be frankly my preference, no reconstruction, the pelvis will just simply rotate. And with a bit of a leg length difference, this patient will do likely quite well without a reconstruction, or a patient without a reconstruction. Thank you.
Thank you. Dr. Thacker?
Yeah, and I think I'm going to echo Deepak's and Kevin's comments here. I don't think that putting in metal into these is without its own challenges, and infection is a very, very real possibility, and then you end up with even more trouble than what you started with. So no reconstruction, certainly well worthwhile in this situation. I also want to commend you on getting that resected beautifully with preserving your femoral nerve and your sciatic. Question for you is, what was the status of the glutei after you were done? Because that will affect what your functional status of that hip is going to be.
Were significantly thinned out by the tumor by the time we were getting in. And so to be honest, I don't think much of it was left. Much of the gluteal musculature was left after the resection.
Yeah, I think that's always the challenge. So, it's great to have a hip that is preserved, but when there's no muscle around it, then the function obviously changes as far as what your anticipated outcomes are concerned. I've had the luxury, I should say,
But
of
just to mention,
seeing.
his iliopsoas function is fairly good. He's able to flex and the hip on his own, which is quite excellent.
No,
So
it's
his main
fantastic. I
challenge
mean,
is the extension part. Yeah, sorry.
yeah, no, what you've managed to do is definitely very commendable. I think that's a fantastic result with what you've had. Had the tumor been closer to the acetabulum, and if you had to resect the acetabulum, it would still have been fine to maybe put a mesh in and put the proximal femur into that little pocket of sorts. I've seen some of Dick Lackman's long-term follow-ups with those kinds of reconstructions, and patients have a limb length discrepancy. It's not a super stable hip, but they tend to do pretty well. They're still able to walk with some crutches and things. So, I think those are certainly choices that we have, and putting in any kind of metallic reconstruction is unwise. So, very nicely done.
Harry, go ahead. You had a comment?
Yeah, and I actually I saw a question in the chat about weight bearing in this patient, which I kind of agree with. So really amazing case, and keeping the acetabulum and the buttress and everything, like Kevin mentioned, I totally agree. I definitely would not reconstruct this patient, but I wonder if he, I personally would probably, I mean, maybe I'd give him a few weeks, but I think he'd protect himself to weight bear. We do a lot of flail reconstruction, even if the acetabulum is taken. And in that case, we usually wait a few months before weight bearing, just to kind of allow everything to scar in and create the new kind of pocket, so to speak, that the femur is going to rest against, and creates quite a leg length discrepancy for sure. But I agree, pretty functional and just for the sake of avoiding infection. But I wonder here if, I mean, could probably weight bear earlier. I mean, curious thoughts on that, or if there was something, of concern intraoperatively too. Obviously, the bone's not perfect with radiation and stuff, but.
Actually, I'd put that more to a lack of experience with this type of case. Personally, it was the first time I was doing this kind of thing. And so we erred on the side of caution, just being more conservative rather than, push the patient to move earlier. I don't think we can give you any specific reason why we took that particular approach.
Yeah, of course. No, I totally understand that. I'd be curious, like Mark and Kevin, who have done many more than I would probably allow this to weight bear earlier than like a straight flail without an acetabulum or sciatic buttress anymore. But
I think Mark has a comment in the chat, which is an important one to talk about. Mark, you want to take that?
It's just that I was a little confused. You talked about taking nibbles from the acetabulum. I assumed the reason you were doing post-op radiation was that there was tumor in the residual acetabulum, and I would just, having had a case exactly like this many years ago, I think if there's a choice between a positive margin and losing the acetabulum, it's probably better to lose the acetabulum. I mean, it's nice to have it if you can get a tumor-free margin, but certainly not necessary. And the difference in function, I mean, there is a difference, but not dramatic enough to make it worth a positive margin. But I'd echo the others, and it was an amazing resection, and well planned out, and I congratulate you on getting him through all that.
Yeah, thank you again. I think this is again what we're saying. We're a learning point. We thought that keeping the acetabulum was really important, but again, that's noted that it's something we can change for future surgeries.
Thank you all for the comments. Great case, Nicholas. Thanks for presenting, and thanks, Nick, for going through the slides and presenting this awesome case. Let's move on to the next one, if you guys don't mind. Next one, we've got Dr. William Gisha from Tanzania. William, do you want to take it away?
Hello, are my slides visible?
Yep, and we can hear you fine. Go ahead.
Thank you very much. Good morning, good day to all delegates. So I'm William Gisha, an orthopedic and trauma surgeon from Moi Orthopedic Institute in Dar es Salaam. In a few minutes, I'll summarize a case of a pelvic tumor who had a late presentation, just to emphasize or share experience in the low and middle income countries, as mentioned in the first talk by Dr. Kuma. Oh, my slides are not moving. Oh, something is wrong. Oh, sorry. Yeah. So our country is about 62 million population, with about 300 orthopedic surgeons in general, but there's no single fellowship trained orthopedic oncologists, just to share the challenges in our settings. And this is where I work. Orthopedic Institute. The institute is actually along the shores of the Indian Ocean. And the issue is to emphasize the delay in the presentation of pelvic tumor patients, but again, to emphasize the role of palliative care. So this is a 38-year-old male who had the left hip swelling for 3 years, which was insidious in onset, progressively increased in size, ended with the difficulty in ambulation and with the weight loss, but there was no other associated systemic symptoms. So as we saw him, he had an antalgic gait with the extensive fungating mass along the hip extending the left iliac region, which was non-tender, fixed underlying tissues, and it was with restricted range of movement of the hip. With normal on the pelvic X-ray, it was an extensive ring and arc fashion chondroiliac wing extending the hip, but again involving the proximal femur. You can see the whole of the left iliac wing involved with the ring. So it was an extensive and forgetting mass. And upon doing further imaging, the CT scan procedure on the left iliac wing, but again the MRI, which was done, which involved, which was associated with extensive visceral infiltration, but again the vasculature. So we thought with this imaging and the condition of the patient, we only did biopsy, which revealed a chondrosarcoma. It was not even further classified. So we thought this was unresectable, such that we could not achieve a tumor-free margin. So we discussed it, and with the chest X-ray imaging to evaluate for any metastasis, there was no metastasis in this patient. So upon evaluation and panel discussion in our setting, we thought this patient should be charged with the tumor board, which is a component of the pathologists, but again, general surgeons and clinical oncologists. Put together, we decided to treat the patient as a palliative patient because the tumor was deemed unresectable. So Otherwise, in initial presentation, if the patient presented earlier, then we would think of pelvic dissections. We've done some few cases here. But again, the aim is actually in this case to share the innovative treatment options which have been there in literatures in delayed pelvic patients with pelvic tumors, pelvic sarcomas. So the grade of the chondrosarcoma, but again, the histologic subtype will decide the type of treatment, whether the patient should undergo complete surgical section or undergo radiotherapy and chemotherapy. So evidence is increasing. Even in delayed presentation, patients will still have their quality of life improved with increasing radiotherapy and evidence on chemotherapy. So the aim in delayed presentation in patients with unresectable pelvic sarcomas is to improve their quality of life. There's increasing evidence on increasing targeted therapies, but again, developing clinical trials and improved ecological principles, which overall have improved the care of this patient. So we have increasing evidence in literatures on level 4 and level 3 evidence on carbon ion radiotherapy, proton beam radiotherapy, but again, chemotherapy, but again, the targeted therapies. This is the emphasis in this patient, such that with delayed pelvic sarcoma patients, we should not condemn this patient to death. The quality of life will still be improved. This is the message in this presentation. So the late presentation now set is multifactorial, but again, the grade of tumor and histological subtype will guide the treatment. But again, palliative care has significant role in unresectable pelvic sarcomas. But again, there's increasing evidence in literature on innovative treatment options, even in late presentation of pelvic sarcomas. Thank you very much.
Thank you very much, William. Just very challenging case. I think we really wanted to include this in the case presentations to highlight the many challenges in limited resource settings of late presentation, lack of access to chemo and radiation therapy and that sort of thing. So just wanted to open it up to the panel of experts here. Would you guys have done anything different? Any comments from Dr. Mugisha's presentation?
I guess my only comment would be the role of external hemipelvectomy, which none of us like to do, but usually is possible in somebody with a quotes unresectable lesion such as this. I would think it should at least be considered as another option.
All right, we thought about that. But again, we thought of the morbidity associated with that, with involvement of the viscera. That was a bit beyond our scope. As I said, we have no single fellowship-trained orthopedic oncologists. These cases are usually managed by reconstructive surgeons, arthroplasts, and pelvic surgeons who have interest in the musculoskeletal tumors. So upon panel discussion, it was deemed unresectable in our setting. Yeah. Apart from that, maybe, yeah.
I guess alongside, if you are thinking about doing an external hemipelvectomy, I assume you would need a multidisciplinary team approach as well as an ICU afterwards. And I'm sure that that's extremely difficult to coordinate in many hospitals.
I'm just interested in the comments about chemotherapy, radiotherapy, because chondrosarcoma, unless for the dedifferentiated type, typically won't respond to these treatments. I'm seeing you quoted some literature, but generally I think the response is still fairly poor to chemo and radio. So it may not have given much. Did you actually give this patient chemotherapy and radiotherapy?
Yeah, so this patient was channeled to the Cancer Institute for the chemo and radio. You rightly said, in the past, the evidence was that chondrosarcomas don't respond to chemo and radiotherapy. So, but there's increasing evidence over the past 4 years that the way you said, they did differentiated, but again, the mesenchymal type will respond to some targeted therapies and radiotherapy as well. So there's a need to further evaluate these patients histopathologically to know the tumor, the histopathological diagnosis and the specific tumor type, so that the subtype, histologic subtype, so that these patients benefit from the radio and chemotherapy as well, and targeted therapy as well. So the patient is channeled to the Cancer Institute for further treatment, and we're yet to see him in the clinic.
Okay. So I think maybe the only thing I would stress is the need for improved awareness, because chondrosarcomas typically take a long time to get this big. So maybe if there was more awareness in the general population about bone tumors, we could have caught this gentleman a little bit earlier. And I think we, just for the whole group, we need to work on how to get the awareness out there so that people can recognize signs and symptoms early. Thank you.
Thank you.
Yeah, great point, Nicholas. Another big important role for your training manual that you're trying to get out in Kenya. I think that's a great move for many, many countries.
The manual is for Africa, we'll share it.
Please do, that would be great. All right, well, let's, for the interest of time, I know we're running out of time here. Let's move on to the next case. Dr. Walid Mekki from Sudan. I think Emily will pull up your slides. Thanks. All right, go ahead, Walid.
Hello, everybody.
Hi.
Hello.
We can hear you.
Yeah, hearing me. Okay, I'm Dr. Walid Mekki. I'm a consultant, adult and pediatric Elizarov and limb reconstruction surgeon at the Seaports Hospital in Port Sudan. Yes. So our patient today hails from that part of Sudan, which is the northern and the eastern part of Sudan. And historically, it was part of the kingdom of Koshites, which were Nubians who occupied that part of Sudan. Yes. So I will give a brief review about giant cell tumors of the bone. In 2020, the WHO have classified giant cell bone tumors as an intermediate malignant tumors. So they usually occur in epiphyseal regions, and they eccentric. They are they feel crackling on palpation. Yes. So of the common locations, from the most common to the less common, we have the proximal femur, the distal femur, the proximal tibia, and the distal radius, which is our case of today. And also it can occur in other parts of the long bones, and also it can occur in the sacrum, and rarely in the skull, in the ribs and the scapula, and in the small phalanges of the fingers. Yes. So epidemiology of giant cell tumor, it represents 4 to 10% of all primary bone tumors and 15 to 20% of benign tumors. 50% of these tumors occur in individuals during their third and fourth decades of life, like in 20 to 40 years, which like our patient today. And there is a slight female predominance in Western literature, but in Asian literature, I came upon a Chinese study published in Nature, which shows a slight male predominance for occurrence of GCT. Yes? So epidemiology and behavior of giant cell tumor, they occur in the subchondral articular surface, but they rarely invade the joint cavity or invade the capsule. They locally aggressive and have potential to metastasize in 1 to 5% of patients. And they have there is a positive correlation between metastasis and local aggressiveness and recurrence. The lungs are the favorite site for metastasis and occurs in up to 35% of metastasis occurs in the lung. Yes. Clinical features of giant cell tumors. Mostly is pain, and which is obvious due to bone destruction. And usually there will be a soft tissue mass or bump. And 12% of patients will present with pathological fractures. And in just like less than 1% of patients, it's multi-centric. And usually it occurs in such case in small bones of the hand and feet and in young patients. Yes? So diagnosis, to diagnose giant cell tumor, we rely mainly on clinical features. We take a thorough history and examination, and with the aid of radiology, we can reach a definite diagnosis. X-rays, plain X-rays can be sufficient in most cases, but we can also add CT scan and MRI. And in X-rays, we see most likely lytic lesions, which are non-sclerotic and extend to subcondylar bone and with frequent trabeculation, and we might see a prostate reaction. And the third tool we have is the biopsy, which is we can do fine needle aspiration or excisional biopsy for histopathology. In the histology, yes, in the histology, next. And the histopathology of the tumor is there is a giant cell tumor with stromal cells originating from osteoblast, and there is a mononuclear histocytic cells and multinucleated giant cells belonging to the osteoclast monocyte lineage. Yes? So classification of giant cell-based tumors, it has been classified by Anakin, but later by Kapanchi, based on radiographic appearance. We have grade 1 of tumors, which are well-defined with thin border, and grade 2 tumors, which has relatively well-defined margins, but no radio-opaque rim, and grade 3 tumors with fuzzy borders suggesting a rapid and possibly permeative growth into soft tissue. Yes. So what are the differential diagnoses of giant cell tumor? We can have aneurysmal bone cyst, chondroblastoma, osteoblastoma, giant cell-rich osteosarcoma, brown tumor of hyperparathyroidism, and fibrous dysplasia. Of course, there are many other differentials, but these are the main differentials that we have confusing us with giant cell-based tumor on X-ray appearance. Yes? So what is the treatment? Usually we have two lines, the non-operative treatment line, which consists mainly of radiotherapy or chemotherapy. I think radiotherapy is not much used like in before. And in radiotherapy itself, there was orthovoltage radiation, which was associated with malignant transformation. And later now we have megavoltage radiation associated with less neoplastic transformation. For the chemotherapy treatment, we use the famous denosum, which is a RANKL inhibitor used to harden the tumor and reduce the soft tissue component. It may also help in converting a lesion requiring resection into a lesion that could possibly be treated by curettage. Yes. Again, the chemotherapy is usually reserved for advanced or inoperable cases, like those occurring in the sacrum, the vertebrae, the mandible, ribs, scapula, skull. I've came across a case occurring in the sphenoid, in the skull, and was the only option was was using denosum as a chemotherapy. And we can also use chemotherapy as an adjuvant preoperatively to reduce the size and to contain the tumor, to convert it into a resectable one. But this have a controversial result in relation to occurrence and even to malignant transformation. Next. Yes. For the surgical treatment, which is the most commonly used, we have intralesional curette with adjuvant therapy. We add phenol or zinc chloride, hydrogen peroxide, usually for cases of Kapanchi grade 2 or 3, with defect filling either with bone cement or bone graft, or combined, which we call the sandwich technique. Or we can use a radical resection with wide margins, in which the case the recurrence will be less than 5%, but associated with morbidity and the need to reconstruct the limb, usually reserved for cases of Kapanchi grade 3 cases, like in our case today. And we can do stage surgical resection plus bone cement and bone grafting, like I did in our case today. Yes. Yes. What is the rationale? I use bone cement as a stage treatment for this patient, but what is the rationale of bone cement? The risk of recurrence is decreased when using bone cement. This has been shown up in a systemic review done by Vaishi. I showed a statistically significant lower recurrence rate when using bone cement in the treatment or filling the voids after resection in treating giant bone cells. The bone semen probably changed the soft tissue bed into an osteogenic membrane on which the bone graft will occupy in the next stage and helps in its fusion with the proximal radius. Yes? So our case today, he is a 36-year-old male presented with history of growing and progressive right distal forearm swelling for the past 2 years. And he had pain, which is more at night, and there is anomia and deformity increasing through time. Actually, he looked for treatment with the traditional. He went to traditional bone setter. The traditional bone setter did multiple cautery marks in a trial to contain the tumor, as he told me. The patient told me he was afraid that the tumor could rupture because it was enlarging. But the patient also was ashamed. He was hiding the tumor by his clothes every time he walks in the streets. And this is the next, yes. This is what he looks up to me when he came to me. He presented to me a very large tumor, a massive tumor occupying the distal forearm and the wrist joint. The tumor size is very large, almost like 20 by 18, 19 and 17 centimeter. And you can see there is a crossing and limiting cautery marks, almost looking, some people have said it looks like a watermelon with those cautery marks crossing longitudinally and transversely. If you focus, you can notice that there was limiting cautery marks on the proximal and distal ends of the tumor. According to his belief, this could help limit the tumor spread. But he told me that he was afraid that the tumor could rupture. Okay, yes, and this is preoperative X-ray. You can see the Kapanchi grade 3 tumor, large distal osteolytic lesion, almost epiphyseal, metaphyseal, and diaphyseal. The tumor now is no longer just epiphyseal, it extends to diaphysis because it has been long-standing for a long time. And we can see the cortical destruction, the soft tissue invasion, and the classical soft-bubble appearance. His chest X-ray, we cannot exclude metastasis. Yes. This is chest X-ray. It shows no clear metastasis, but I think to confirm, we need to do a CT scan for the chest. So treatment strategy for this patient was a staged removal of the tumor and reconstruction using autogenous fibular graft. Because the patient encounseled him, he refused to do rest arthrodesis. I did a careful resection of the tumor with preservation of tendons and neurovascular structures. I did also meticulous removal of all remaining tumor tissues and aggregates and curate of the proximal part of the radius. We did saline wash. I didn't use any adjuvants. I just used saline wash and did apply bone cement to fill the void as a stage 1. In the next stage, after 6 weeks, I did remove the bone cement and fix the defect with fibular graft using just a DCP, and I fixed distal fibular ulnar synostosis by K-wire. And now 8 weeks, I sent him for physiotherapy. So this intraoperative images, I did the elliptical incision to excise the redundant skin. I was very careful in dissecting the tumor, removing the tumor, preserving the tendons and the neovascular bundles. And finally, I was able to do an in-block resection in line with the separation lines of the tumor. Yes. This is post-operative X-ray, stage 1. You can see the bone cement filling the defect. Yes. And this is in the next stage after 6 weeks. If you can notice, there is a osteogenic membrane with developed lips. I put the lips actually of the incision where I removed the bone cement. It was very thick and well developed, like a muscular technique. You can see that thick soft tissue developing. And I did a radiofibular fixation using autogenous fibular graft and distal fibular ulnar fixation using K-wires. This is post-operative X-ray after the second stage. You can see the fixation of the fibula and the distal fibular ulnar synostosis. Yes. This is the final X-ray. This is final clinical photos. how he looks. His tumor is well removed, no infection. This is just 8 weeks now post-operative. He can flex and extend all his fingers. At the first, he was having just a neuropraxia. Just immediately post-operative, he wasn't able to move his fingers. I related to neuropraxia, and that's what exactly is having, because now he's improving. After 6 to 8 weeks, he start to move his fingers and start to develop sensation, and everything is improving now. Now I sent him for physiotherapy. And that's it. Conclusion. So patient education about the feasibility of treatment. They shouldn't be ashamed. They should be encouraged to seek medical attention and care. And there is also good functional outcome. The patient is improving. And there is a need for follow-up, of course, in such a large tumor, because the chance of recurrence is, I think, is a bit higher in this case. And the treatment should be individualized after well counseling to the patient. So references? Yes? Yes?
Thank you, Walid.
Yes? Yes? And thank you. Yes, fine.
Thank you very much. If we
Thank
could
you very much.
to the preoperative X-rays, just for the purposes of discussion, I'll open it up to the faculty. I mean, fascinating case from the perspective, you know, of a hand and upper extremity surgeon like myself. I think it's a very unique and challenging case, and you did obviously a superb job of reconstructing. My question for you is, did you consider transposing the ulna over instead of using a non-vascularized fibula?
This for me?
Yeah.
Yes, but I didn't go for this option. I prefer to use the autogenous fibula.
Mm-hmm. That's one technique that I remember from my training in a recurrent case of giant cell tumor. We just transposed over the ulna and then used that to fuse the wrist. But no, I think obviously how was the outcome for this patient? The patient's getting through physiotherapy, but seems to be doing okay.
Yes, he's improving very well now, and also he's very happy because the traditional bossetters told him that if you go to doctors, they will amputate your limb. But now he's very satisfied and think his idea is wholly changed about doctors and surgeons. Yes.
Yeah. Well, he was lucky that this wasn't a malignant tumor, for sure.
Yeah. Thank
Any
you.
comments from the other faculty?
It was unclear whether you saved the articular surface of the distal radius and then put the fibula into, or you know, to support it, or whether you took out the articular surface.
No, I mostly scrapped the articular surface.
So you preserved it?
No. I took the articular surface.
Took it out. Okay. You can also
actually there was just a very few remaining tissues because this has been for a long time standing. Yeah.
The other option using the fibula is to take the entire proximal fibula and use that as an osteoarticular autograft, which has been done a few times. And it actually looks not too dissimilar to the radius when you put it in there.
Yes. I know this, but my thought was of the patient could have a higher recurrence rate and the morbidity will be much higher if I took that part of the fibula. Although it's shapely and more looking like a distal radius, but that was my option at that time.
Nice job. That was good.
Yeah.
The only other comment I would make, we got excited when denosumab came out, and now essentially almost never use it unless it's a totally unresectable tumor. But if you curette a lesion after denosumab, it is much more difficult. It turns the tumor into leather, basically, and it's really hard to curette the tumor once you've used denosumab. So if we're thinking curettage, we don't use denosumab.
Interesting. Dr. Belzarena, Dr. Heinzelman, did you guys have any comments to add to this case? I just wanted to pull you.
I agree. It was a very tough case, and it's especially difficult when you have like limited resources. So I think the surgeon here did a great job with what was available. Yeah.
Yeah, agree. Not much to add. I mean, one this advanced definitely need a resection, and I think the reconstruction looks really good. You saved him from, you know, the things he was worried about. As you said, at least maybe he'll be more inclined to come for follow-up and stuff if he now trusts, you know, the medical institution better. So I think that alone is a huge win.
Yeah, really excellent. Thanks, Walid. For the interest of time, I know we're getting a little over. I just want to get to our last case, if that's okay with all of you. So Dr. Zubair, do you want to present your case? It's also a case of giant cell.
Yes, sir. Hello to everyone. Am I audible?
Yes, go ahead.
I'm Dr. Zubair, working as Senior Registrar in the Department of Orthopedic and Spine Center in the Guru Ki Trust Teaching Hospital, Lahore, Pakistan. I'm going to present a case of the GCT of the distal femur in a patient with a 22 years male laborer by profession. He presented to us on the last year on the 1st of November with the pain and swelling of the right knee since 6 months. And there's aggressive increase in the swelling for the last 2 months, with there's no generalized symptoms appreciable in this patient. On examination, there is 7 to 7 centimeter mixed consistency swelling of the right distal femur with overlying skin normal with joint and palpable. And the range of movements is 15-degree flexion to 40-degree. And there is a painful range of movements. However, distal neurovascular bundle is intact and there is no lymph nodes involvement there. This is the X-ray of the patient, which showing there is a distal femur lesion which extended into the adjacent soft tissue. And however, the joint is looking normal. And X-ray is showing there is a Campinachi type 3 on the GCT. We go with the MRI and we show this extensive involvement of the adjacent soft tissue with the preservation of the neurovascular tissue. So we did the HRCT, which was normal at that time, and we planned for the tumor workup with core-needle biopsy, which showed there is a joint cell tumor of the right distal femur. And as this is a Campinachi grade 3, we discussed with the patient and started the denosumab 120 mg subcut for the 3 weeks, and we perform a surgery on 23rd of November. And we discussed the patient as the patient is a laborer and he has to perform his daily activities, so he goes to the knee arthrodesis. We plan with the tumor excision of the right distal femur with the right knee arthrodesis with a custom built nail with the rotation of the proximal tibia medially and non-vascularized fibular graft. In the preoperative planning, we arrange the X-rays of the 100% magnification and measure the size of the nail according to the patient. It was developed by our local vendor with this is a solid type nail and with holes at the desired area which we pass the screws. So this is the lesion which we measure at and then preoperatively, and this is the preoperative in the intraop pictures with showing there's a 10. We dissect the the tumor with the clear margins, and the gap was 10 centimeter. So we rotate the proximal one-third of the medial tibial cortex and rotate proximally to the femur and take the 10 centimeter fibula, which is non-vascularized on the lateral aspect. This is a picture and another view. We apply the 1/3 tibial plate on the proximal aspect and the screws which we designed, the holes which we designed in that nail, the pass the screw from the fibula to the nail, and also apply the for 6.5 cancellous screws in the distal part of the medial part of the tibia. This is a diagrammatic presentation in which we basically resect one cortex of the medial side of the tibia in this way and this, and they rotate it proximally. So this end goes to the distal femur, and this is stay here. And we take the non-vascularized fibula of the 10 centimeter and place there. And this is the X-ray out on the first post-operative day. The protocol would start the denosumab for on every month for 6 months, and do the chest X-ray after every 6 months. This is the follow-up X-ray after 3 months, which shows there's a good union in the both regions. This is the follow-up X-ray after 6 months. And this is pretty solidly united. And the patient is working in one of the petrol pump station. This is the video of the patient with his consent. And he's walking just like some limping gait because of this the knees arthrodesis. And he's very happy because he was told someone that it will recur again, but now it's almost 1 year and he's enjoying his life.
Thanks, Zubair. Fantastic case. Really creative option for reconstruction here. I'd like to open it up to the faculty to make any comments. Would you guys have done anything different? I'm sure in a high resource setting, perhaps this would be an endoprosthesis reconstruction. Curious what other options people would have had here.
Yes, in our center, we also perform the distal femoral replacements, but this patient is non-affording and not able to bear the expenses, and his lifestyle is totally not able to work after that, the distal femoral replacement.
Yeah, and obviously a high risk of infection and failure and revision.
Yes.
I get that. Dr. Ilyas, I think, was the consultant for this case.
This was developed by the technique developed by the Dr. Saad Ilyas.
Great. Well, Mihir, I see that you have your hand up, but just before you go, I'd just like to invite Dr. Ilyas to make a comment since this is his case. Ilyas, would you like to make a comment?
Yeah. Actually, Zubair is the one who did this case. We have done about 15 cases, and the longest initially what we did is I thought that since we rotated tibia or femur, the metaphyseal part, we thought that union in this part would not be a problem. In my initial cases, I resected out the common peroneal nerve and took out did an osteotomy of the fibula and attached it with its muscles attached, so that I thought maybe vascularity on the fibula will help. Well, later on, we tried using a free fibula, and we thought that, and in all of our cases, the fibula united anyway. So now we are just doing a free fibula transport, and the longest, I think it's about 12 centimeters. So the longest gap that we have covered after resection is about 12 centimeters. As Zubair is actually working on the paper as well. So hopefully in a few months, you'll be able to see it as well.
Look forward to reading that. Thanks, Saad.
Yeah.
Mihir, did you want to make a comment?
Yeah, no, I think this is great. In way of background, I grew up in India, did some of my orthopedic training in India, and certainly this is something that we've utilized back then as well, and it works. It clearly works quite nicely. 2 questions for you. Number 1 is, if you're in a low resource setting and you don't have access to the custom nail, would a set of 90/90 plates work just as well? And then the other question is, since you have such phenomenal expertise in limb lengthening reconstruction, could you consider resecting it and then doing bone transport and then achieving your knee fusion that way?
Well, actually, we do at our center, we do segment transports as well. Usually, I was doing bifocal corticotomies and transports with a massive bone defect, and the largest distance was about 26 centimeters. So, but with this, because in these patients with tumors, the patient's going to take chemotherapy, they're going to have union problems, and infection rate is pretty high in these patients as well. So with this technique, we thought maybe because segment transport, it takes a lot of time, then there are union problems. So these patients were, even though we were doing it, but this felt easier for the patient and for us as well.
Fair enough. And then if I may, one more question, Kiran. did I see something about post-op denosumab, and what was the rationale for that?
Actually, we we do give for about 6 months, once a month. Well, what we saw in GCT, one is if there is a recurrence. We saw in a few patients. I think last recurrence I saw in a distal radius patient of mine, but that recurrence consolidated, and it was easier for me to resect that. And plus, what we feel that resection, denosumab also helps with union as well. So this is our observation. In patients in which we resected out the GCT and gave denosumab, we felt that the union was a bit quicker on those patients. That's an observation at our setup. I don't know whether it's published or not, but this is what we saw.
That's very interesting. I wonder if Kevin, Mark, and everybody else has a comment to make on the denosumab union observation.
I don't think we've used it sort of as adjuvant post-op therapy. It may not be a bad idea. The comment on the knee arthrodesis is it's a very good reconstruction functionally, and we used to do a lot of these using allografts. Enneking and Campanacci used the autograft technique with a long nail like you did. And, no one likes a fused knee, but it works really well, unless you're sitting in a crowded place. And I remember one time at a meeting, they, Enneking, Mankin, and I don't know who the third person is, brought patients that had a knee arthrodesis, an osteoarticular allograft of the distal femur, and endoprosthesis, and showed their function. And Enneking sort of won the day because his patient was able to play tennis with the knee arthrodesis, but nobody with an osteoarticular allograft or an endoprosthesis was able to do, sports. So it is a very functional reconstruction, and you did a great job with this case.
I'm sorry I had logged off for a moment, but I just to make a comment, I don't have any experience with using denosumab in union, as you asked, but denosumab is a funny thing. We use it to solve an immediate problem, some rapidly growing destructive tumor in a hard to get to place, like in the acetabulum or the sacrum or something like that. And it works really well. It stops the problem, but it doesn't make the problem go away. And that's what we're learning. I think, at least here, we're learning about denosumab is once you give the drug, it works really well. It stops the osteoclast phenomenon that is giant cell tumor of bone, but it doesn't make the problem go away, in that if you withdraw the drug, the tumor comes back, usually. So then you're kind of stuck in this world of what do we do now with a patient on denosumab? So we've been using it more as an adjuvant to stop tumor growth sustainably for, say, 3 months, 6 months, and then resect and look at it almost like a sarcoma and remove it as such, especially in the distal radius, proximal fibula, and even around the hip. That's a situation where we either keep the patient on the drug, or we think of surgical resection and not intralesional surgery, because with denosumab, intralesional surgery is extremely difficult, if not impossible. And if you really want to perform an intralesional operation, then you're going to have to come back off the denosumab. Then you're staring at the same problem you started with 6 months prior. So I'm less attracted to the use of denosumab as a temporizing or as a permanent agent. We're using it mainly as a temporizing agent in consideration of resection if we cannot do an intralesional operation.
Thanks, Dr. Raskin. Great comments. Well, we're getting close to the end of time here. I don't know how you guys feel about trying to squeeze in another case. Dr. Mgisha, I think for the purpose of time, do you want to try to give your case presentation very, very quickly? We got to end in the next like 5-10 minutes though.
Oh yeah, so I'll make it maybe in 3 minutes. I'll summarize it in 3 minutes.
All right, why not?
Yeah, so it's a case of a knee preservation surgery in a delayed presentation of a giant cell tumor in a 23-year-old female who had a right knee pain followed by swelling, which progressed over 1 year with no history of trauma. So she was a young lady who was not pale with no regional lymphadenopathy. She had a flexion of about 100 degrees. So we thought she still had some movement of the knee. And this is her appearance on the clinical photos. So the difference in the circumference between the left and right knee was only about 4 centimeters. So it was not a very significant swelling clinically. And this was the initial X-ray which she had in the regional hospital before she visited our center. You can see the lesion was osteolytic subarticular, not not extending to the soft tissues. So biopsy was done on arrival at our center. This is when she presented 5 months with the lesion at our center. This is when we biopsied and came out as a giant cell tumor. You will see an extensive osteolytic lesion, which was subarticular, but again, sparing the soft tissues. So she was lost to follow-up, and she was only on a knee brace. We again saw her at 1 year. We can see the tumor was almost shrinking with only bracing. She did not receive any neoadjuvant denosumab or another therapies, and there was no metastasis. So we would basically see that the tumor was extending to the posterior compartment of the knee, but not encroaching to the vessels. So the giant cell tumor Campanach grade 3, we initially thought of referring the patient for endoprothesis, but again, she could not afford, and the cost of referral abroad, we don't have the endoprothesis prothesis at our setting. So as she came, we thought we could do a knee preservation surgery. So we basically did extended curettage with mechanical erectic burr, but again, thermal curettage with the electrocautery, but again, hydrogen peroxide. And we filled in the defect with bone cement. And they did fix the cavity with bone cement, but again, the intramedullary plates, the reconstruction plates, which are just placed to support the reconstruction, but again, a medial plate, which was applied through a posteromedial incision. So this is what we did. And on rehabilitation, you would see we kept on toe touch weight bearing, and the incision healed eventually at 3 weeks. And as I saw her on the 6 weeks follow-up, the subarticular surface was almost healing. The tumor was not going to the joint as much, and she could flex the knee to more than 100 degrees now. So we think this will work for her, and in the long-term follow-up, we think this will help the patient, and she will have escaped endoprothesis replacement, especially at her tender age of 23-year-old. So Campanach grade 3 of a proximal tibial metaphyseal lesion could be preserved if it did not breach into the articular surface through extended curettage, of which we know should include the mechanical electric burr, electrocautery, but again, chemical, like the use of hydrogen peroxide or phenol. But again, I think endoprothesis should be a consideration in a case where you cannot preserve the knee. This is the measure. Thank you very much.
Fantastic. Great presentation to end on. Dr. Raskin, since you gave the talk on giant cell tumor, I'll let you make the first comment on this one, if you don't mind.
I just put my comment in the chat. I mean, I think this is the standard of care in a giant cell tumor in this location. This is well done. This is absolutely well done. You mitigated complications as best as possible. Thorough curettage with some sort of adjuvant, whether it's liquid nitrogen or an argon beam or whatever. This is well done. Well done. Congratulations.
Thank you.
Would anybody have tried something different, like performing a knee arthrodesis or a megaprosthesis or something like that?
mean, I think this woman will likely have some other problem in the future, like arthrosis of the knee and arthritis, and that's when you might consider an endoprosthetic. But primarily, at first blush, no. I personally would do exactly this. I would do a curettage, intralesional surgery, and try and preserve the joint.
I agree. And when we first started using cement, I think was described in Brazil, we worried about the subchondral bone, and sometimes we put bone graft under it. I think we were probably treating ourselves rather than the patient. And the amazing thing is that the articular surface holds up as well as it does. So it's a theoretical concern, but these joints tend to hold up remarkably well. So great job.
There is a question in the chat asking if you're going to keep the cement or plan on grafting.
Yeah, we did not combine the graft with the bone cement. We only did bone cementing. We did not do any grafting.
And I think your plan would be to leave the cement in there, right? To not go back into it.
Yes,
Yeah.
exactly. We will not remove it. Yeah.
That's great. Well, thank you all for a fantastic session. Really appreciated all the cases, diversity of opinions, and pathologies. Thank you very much. Emily, do you mind pulling up the file? Yeah, there we go. Great. Well, thank you, first of all, to all of the case presenters, and then, of course, to all of the faculty. Really do appreciate your time, and thanks for sticking around a little longer than usual, just so that we could get through all the cases today. As many of you who've attended our sessions before will know, if you attend these live sessions, please fill out the pre-conference and post-conference surveys for each session. We'll be very happy to give you a certificate of participation for having attended all 3 sessions. You don't have to have done it over the course. We will send out all the links afterwards so that you guys can go through and learn at your own pace if you'd like. And just as a reminder, all of the lectures by Dr. Balzarena, Dr. Raskin, Dr. Gebhardt, Dr. Ramkumar are all available for free in multiple languages on our YouTube page for you to go through. So thank you very much. Next slide. We have this wonderful WhatsApp community that has been growing over the past year. These are the QR codes to scan and join. We oftentimes share cases on there. There have been a few cases of, primary bone tumors, metastatic bone disease shared in the lower and upper extremity surgery groups. And certainly if there's enough interest, we'd be happy to create new groups specifically for these topics. Based on this excellent presentation, I think there's certainly enough to talk about, enough people interested in this. Thank you. Oh, and last but not least, stay tuned for our next online virtual education conference series, which is coming up in November into early December on complex upper extremity. So thank you all. Really appreciate the time and the participation. I'll leave it open to anybody who wants to make a final comment, but we'll end it right there, I guess. Thank you.
Thank you, Karen and everyone.
Thank you.
Thank you. Take care, everyone.
Thanks a lot, Kiran. Very well done. Despite all the little hiccups this morning, it was fantastic cleaning things up.